stragglers coming in a little bit. So it's my great pleasure to introduce Dr. Johnny Morrison, who is an assistant professor of surgery at the Shock Trauma Center down in Baltimore, where I worked with him as a fellow and had the great privilege of being trained. He is originally from Glasgow, Scotland. He came over after being trained in both trauma and general vascular surgery. He deployed to both Iraq and Afghanistan in the British Army, and recently came over to Shock Trauma Center, where he practices both trauma and vascular trauma surgery, and he's going today to talk about that. Thank you so much, Dr. Morrison.
Good morning or good afternoon. Many thanks for the invitation. I really appreciate the opportunity to come and share some of our lessons and experiences that we've kind of gleaned both the easy way and the hard way at the Shock Trauma Center. Hopefully this talk will be both illuminating and may provoke some questions about how best to deliver vascular trauma care. So the title of my talk is Integrated Vascular Trauma Care, not exactly vascular surgery or trauma surgery. And really the point that I'm trying to make is that there's almost a case for a little bit of a subdiscipline that crosses both vascular surgery boundaries as well as trauma surgery boundaries, that certainly doesn't make it a discipline in its own, but there are some things that merit specific consideration. And most of our lessons have been born out of the experience of having a dedicated vascular trauma service that I'll elaborate on as we progress through the talk. Importantly, my conflicts of interest, I'm on the Clinical Advisory Board of Primetime Medical, which is a company that makes Cerebral catheters, and I also speak for Terumo Interventional Systems, which makes endovascular devices for bleeding control. So first off, what do I mean by vascular trauma? In simple terms, this is injured blood vessels. Really, there are two kind of main manifestations of an injury to the blood vessel that kind of catch your eye, and that's either hemorrhage, which is often the most dramatic, or ischemia, where the end organ supplied by that blood vessel has its blood flow compromised and is dysfunctional. And certainly in the extremities, ischemia, sometimes can be very obvious, but for a lot of times it's a lot more subtle, and certainly when it's affecting one of the viscera, that may not be obvious at all. Importantly, there's also the iatrogenic causes of trauma that we see from other endovascular practitioners, but crucially, vascular trauma is also common to all surgical disciplines, and that if you are going to make an incision in somebody, if you're going to put a needle in something, there's always a risk of injuring something. And what that means is that everybody needs some level of experience, even if it's just the ability to recognize when you need to pull the needle out and hold pressure, and then to be able to assess whether or not that maneuver is successful or not. But as a consequence of the exposure that we've had with trauma at the Shock Trauma Center, we've been able to devise a bunch of techniques that are very much specific to vascular trauma. These are not things that you would necessarily use in an elective vascular practice. There's a large proportion of them that you absolutely wouldn't. And then all of these maneuvers provoke questions in terms of how do we train the next generation of practitioner to look after vascular trauma patients, bearing in mind some of the endovascular techniques may not be germane to trauma surgeons. And likewise, if you're a vascular surgeon with a practice specifically focused on age-related disease, some of these maneuvers may not necessarily come naturally either. And these are some of the challenges that face us in the future. As I say, what's special about vascular trauma? Well, in terms of management over the last kind of 10 years, and the study that I'm putting up is from the decade prior, and really what this shows is that the big thing that's changed is the proportion of cases managed by endovascular techniques. And endovascular techniques suddenly start moving vascular injury management with the domain of the majority of trauma surgeons, in that the open exposure of blood vessels and the application of clamps, I think is very much within the purview of vascular surgeons, but the notion of putting a stent graft or embolizing something, it tends to be a little bit more foreign. Now, all of this is, is a great thing to discuss and think about. But the one thing that makes trauma special is that a lot of it is time dependent. You can't have somebody who is bleeding or somebody who's got an ischemic organ. You can't just put them on the back burner and say, hey, do you know what? We're going to, send out for a specialist who's, 2 hospitals away, and we're going to get him over and that'll take care of things. For some clinical problems, that's fine. But when it's a time dependent pathology, that adds an extra dimension. In terms of the kind of classic model of vascular injury care, you tend to have the injured patient and they're looked after by the trauma service. And then what happens is the trauma service then interfaces with a variety, a constellation of other practitioners that can help to deliver intervention, be it vascular surgery, interventional radiology, neurointerventional radiology. And often this is done in a serial fashion. You've got the attending that talks to the trauma resident, the resident then talks to their vascular surgery resident, and they may or may not talk to their fellow and attending. So you've got this kind of, up and down system that can sometimes makes expeditious management of time-dependent pathologies problematic. And the one thing that I kind of tend to talk about is the biggest risk in all of this is surgery by committee, where you've got a bunch of people that say, oh, this isn't my responsibility, this is such and such a service's responsibility. Oh, did I hear that there was a big toe fracture? Well, this really, the orthopedic surgeon should really be involved in this, and on it goes. And that's why streamlining that system becomes more urgent. When you look at hemorrhage, as a clinical entity and as a cause of mortality, we find, very squarely within the civilian literature and the military literature that the bleeding remains the leading cause of potentially preventable death. And that all is surrounded by the notion that if you can get somebody to the operating room and apply a clamp to their bleeding vessel, then you can stop their exsanguination, you can then restore their volume, and from there you're able to salvage the patient. And that's why hemorrhage certainly has got a very big boost from DoD research in the last 2 decades, born out of the experience in Iraq and Afghanistan. But these lessons are very applicable to civilian trauma. And really the wake-up call for us at the Shock Trauma Center was when we looked at our potentially preventable hemorrhage-related mortality. We found that almost 80% of deaths from hemodynamically unstable pelvic fractures could be attributed to early uncontrolled hemorrhage. And our median time to embolization was about 5 hours, which when you think about it, within that time period, if you think about a patient who's bleeding, an awful lot can happen within that time period. And that really forced us to have a little bit of a look at how that classic model of vascular injury care was delivered on the basis that we really had to kind of think out the box and come up with something a little bit more meaningful. Now, this is an aerial view that I've pinched from Google Maps of both the Shock Trauma Center and the University of Maryland Medical Center. And what I've drawn on there is the city block that it takes to get from our trauma resuscitation unit to the interventional radiology suite. And what we found in critical interventions where, for example, embolization was required, this was just taking too long. When we had our new surgery tower and critical care tower built, this included a hybrid room, and this is room 11, which is kind of home sweet home for our vascular trauma service. And this hybrid room has a fixed C-arm system that allows us to do a lot of sophisticated imaging interventions delivered concomitantly with surgery. And this is one of the things that's really changed how we deliver care. And importantly, not only is that now within the surgical domain, but it is much closer to the trauma resuscitation unit. We are now a roll down the corridor rather than having to take an Uber to get to the other end of the hospital in order to deliver some of these interventions. And really what we've done is we've changed this model of vascular trauma care delivery where the injury patient that was owned by the trauma service, and what we've done is we've nested a dedicated trauma vascular service within that paradigm that works for the trauma service. And what we have now is a bunch of dual trained vascular surgeons and trauma surgeons who work with the trauma service in a dedicated way purely for vascular injury management. And that can be anything from age-related problems, but our primary mission is all about hemorrhage control and or urgent revascularization. And by cutting through some of that traditional paradigm of care where you've got other subspecialties that you involve, this is dedicated to the trauma service and means that the accessibility is much faster. This was kind of the great trio until a few months ago. I'm on the left. On the far right, we've got Joe DeBose, we've got Dr. Scalia, who's very much kind of led this this endeavor and is really kind of redefining how we do this. And then to the left of Dr. Scalia is Rishi Kundi, who he and I are now the kind of mainstay of the trauma vascular service at Shock. And this is a recent paper that we published in the Annals of Surgery, where we kind of describe this experience and what this has done to a number of key clinical metrics, specifically time to hemostasis and our case volume. And what we found was that, number one, we do a lot more cases, but crucially, we're able to do all of these things faster. In that our time to pelvic fracture has got, average embolization to pelvic for a hemodynamically unstable pelvic fracture has gone from that median of kind of 5 hours down to almost 2 hours. And that has really been facilitated by having a hybrid room where we can do all of these sometimes simultaneously with open surgery, but usually in a kind of serial fashion. So I hear you all thinking, well, this all sounds exciting. This all sounds interesting, but what does a vascular trauma surgeon actually do? Is there enough work to be able to, have this service actually do things in a way where they're not sitting around for an extended period of time? And really that is the kind of nub of the question, in that you've got to have a crucial volume outcome relationship where you've got to have enough work to be able to justify a service like this. And it's also got to be sufficiently interesting. So what I've put up there are kind of really what I would say encompasses about 95% of what our workload is. Primarily, we're focused on named vessel injury, where that is the endovascular management of aortic, subclavian, iliac, and cerebral vessels, and the exposure and repair of extremity injury, fem, pops, tibials, as well as upper extremity stuff. We help in the management where adjunctive techniques like REBOA and cable occlusion are required. So what I've got in the upper picture is a IVC injury that we've put a bridge balloon through, and that's nicely controlling a hole in the IVC that came about from a gunshot wound. And that involves getting femoral venous access, putting in a femoral sheath, putting in a cable occlusion balloon, which is a long sausage-shaped balloon, which is a big compliant balloon. And then we'll often put a REBOA in at the same time to balance the kind of afterload requirements as we cut off the preload. So, there's a whole kind of bunch of things around these adjunctive techniques that we do often synchronously with open surgery. We do some of the traditional interventional radiology type work, such as pelvic angio embolization, solid organ angioembolization. And then we also manage all of the kind of venous disease that comes about with trauma patients. And certainly in a center that does ECMO, where you have a lot of catheters and big catheters at that. In the IVC, we certainly see a lot of venous disease that requires, a mixture of filter management, both insertion and removal, as well as thrombectomies and various other things. This experience has allowed us to kind of develop a number of techniques, and we've kind of built up solutions to most of the problems that we see day to day. Some of these are pure endovascular solutions. So for example, axillosubclavian injuries, either distraction from blunt trauma such as motorcycle collisions to blunt injury with, through to penetrating injury with gunshot wounds. We've kind of now developed a kind of escalating tier of endovascular interventions that really mean we've been able to eliminate really the need to kind of explore that particular blood vessel in stable patients. What I show here is a kind of picture of the kind of classic antegrade stent, where a wire is passed from the femoral artery, is navigated up with a catheter into the subclavian, and then it's crossed the lesion, and then a stent graft is deployed. If that is unsuccessful due to distraction of the injury or due to thrombus that occludes it, Then we use a technique that was described by a bunch of interventional radiologists in Houston, where we'll pass a wire from the left radial artery, and then we'll catch it with a snare from the femoral artery, and that allows us to do this rendezvous technique where we're able to then get wire access to allow a stent. And then we've developed this internal external wire capture technique where if we've got a blood vessel that is so distracted that we're unable to use a snare, what we'll do is we'll pass two snares from antegrade and retrograde, and then what we'll do is we'll line our C-arm up, and then through the skin we'll pass a needle that will catch both of those snares and allow us to pass a wire and pull that through, and that enables us to be able to span the defect, and this way we've been able to really have no such thing as an impassable lesion when it comes to subclavian injury. I'm sure everybody's familiar with the notion of blunt thoracic aortic injury and how TVAR, thoracic endovascular aortic repair, has kind of revolutionized that injury. Almost exclusively, I would say that blunt thoracic aortic injury is managed endovascularly. We've now been working on some data that suggests there's a higher preponderance of cerebellar stroke in patients without revascularization of their left subclavian. So we don't think that that's maybe as benign as we had previously thought. Traditionally, if you're going to cover the left subclavian and if you need to revascularize it, one would do an open carotid subclavian bypass. We've been using a technique of laser fenestration where we advance a laser down the left arm. We bring that to the fabric of the TVAR graft once we've deployed it, and then we burn through the graft and then deploy a stent into that left subclavian that allows blood to flow from the aorta into that left subclavian. And this is certainly an age-related technique that we've kind of extended to the trauma domain. So that certainly isn't anything novel in its own right, but its application to trauma kind of shows the potential application of these techniques. But crucially, I would say that where we've really kind of led the field in terms of some level of novelty has been in the combining endovascular and open intervention in combined visceral injury. And certainly the two groups that are fairly big are liver trauma and pelvic trauma. And this is a little bit of a complicated slide from a paper that we just published in the Journal of Surgical Research, but this kind of outlines kind of our philosophy around triaging patients who we think may benefit from a hybrid room. And this is patients such as hemodynamically unstable liver gunshot wounds, where we'll take them to the operating room, do a laparotomy. First of all, we'll pack the liver, but if we don't have good hemorrhage control, then from there, rather than doing things like surgically resecting the liver and indulging in bigger and bigger procedures, we can do an on-table angiogram and embolize bleeding areas. And certainly that doesn't negate the need for potential liver resection, but allows us to get earlier hemorrhage control. And here's a picture of one of our previous fellows. Down in the left-hand side, we've got a liver, which the right lobe has been packed off. That particular fellow is using an ultrasound machine to get radial access to the right radial artery. And that allows us to then get a catheter into the celiac axis and into the hepatic artery. And then from there, we're able to selectively embolize as distally as we can at the kind of site of the bleeding focus. And that has allowed us to, although we've still done a laparotomy and we've still done maximally invasive surgery, it means that the actual organ itself, we've been able to do some, relatively organ preserving things that maybe minimize the kind of surgical injury that happens. This is a systematic review of the kind of complications that we see with angioembolization for livers. And as I say, this is, embolization is rarely employed as monotherapy, and usually it is accompanied with other operative techniques. Importantly, having a dedicated service allows you to understand and anticipate some of the complications that you may see. So for example, it's well described that the kind of rate of biloma is a little bit higher if you have to use angioembolization. And having a dedicated service kind of does allow us to have a practice pattern where a lot of these things are able to be anticipated and planned for. Because complications are not about the actual complication, they're about how you manage them and how you anticipate them and how you prepare for them. And what we've really found is that selectivity is very much the key. And this is actually the embolization that we were doing in that picture a couple of slides earlier, and really getting as distal as you can within the arterial tree. And we're starting to get into some of the specifics of technique that I can elaborate on if people are interested with questions later. Sticking with livers, but kind of trying to demonstrate the kind of benefit of combined endovascular and open procedures in visceral surgery. The liver is one of these complicated organs that has a real propensity to bleed, and we've developed a bunch of kind of hybrid techniques where we can access all of the various blood vessels involved in bleeding within the liver. And a lot of people have focused on angioembolization. You also have bleeding from the portal system and from the IVC. And for anybody in the audience that's ever managed IVC bleeding, that's pretty horrific. Uncontrolled IVC bleeding is probably the worst in the world, in that you've got this kind of low pressure, high volume system. And if you get into a retrohepatic caval injury where one of your hepatic veins has been avulsed off the IVC, that's a real problem. I'm a lot less scared of that than I used to be, partly because of the advent of the bridge balloon, and that's kind of allowed us to be able to place this in the IVC that then occludes those tears, and it gives you chance to surgically get to these lesions without losing gallons and gallons of blood, because you've already got endovascular control. And quite often, we're certainly seeing in shock that as our kind of confidence and familiarity with these techniques grows, we are able to employ these more frequently in a more thoughtful way, so that we can really minimize the kind of surgical hit that occurs with patients. This has required a lot of growing pains. The surgical techs often don't like having a combined case, because you start running out of space on your table. Our response to that has been to purloin the double-decker table from our orthopedic spine colleagues, and this has enabled us to have one of the decks dedicated to endovascular instruments, and then the bottom deck dedicated to open instruments. So we've kind of had to learn a little bit of how we do these things. We don't always get our triage correct for our hybrid room, so we have to have a contingency of being able to move hybrid surgery into one of our regular ORs, and that's just a case of bringing one of the mobile C-arms and bringing that into the room. We've developed some kind of slightly nonsense techniques like TIMV, trans-inferior mesenteric venous, or venography and embolization, where open surgery, you're able to access the inferior mesenteric vein, and really in the setting of ongoing liver bleeding, especially in the face of coagulopathy, the portal system is often one of these systems that's kind of overlooked, in that it's felt that it can be just managed with packing. Certainly we've had to do a number of venograms within that vascular domain, and we have had some lesions that have required therapeutic intervention. That almost always comes with the need for a liver resection, because by the time you're taking out the portal circulation, you've often got really quite an extensive injury. And then from there, you've got other radiological things that you can do when you're on the table. This is a liver that I had a couple of weeks ago that I've had to take a wedge of liver out following a gunshot wound. This is a subtotal cholecystectomy that I did, and then at the relook surgery, you get the duodenum just above. At the relook surgery, I reopened that subtotal cholecystectomy, and then have passed a wire and a Finelli stent over that to decompress the sphincter of Oddi to
allow that big raw surface chance to heal to minimize the need for a bile leak. This is the cholangiogram or a plain image from the imaging system with a cholangiogram following it on the right hand side, and this demonstrates, if my pointer works, here's a compi catheter that we've passed down the cystic duct into the bile duct. Here's our Finelli stent that's crossing the sphincter body. This is contrast freely flowing into the duodenum. And then this is extravasation of contrast in the setting of disrupted bile canaliculi from that big raw surface earlier. And I'm pleased to say that that patient, ultimately went on to have a fairly minimal output from his drains in terms of bile. So there's a bunch of these things that having an interventional orientated service will allow you to do kind of some of these spin-off procedures. The other domain that we've really, I think, proven our worth has been in the setting of pelvic trauma. This is a patient who's in the hybrid room that has got a C-clamp applied. They've also got a Reboa catheter up, and that's been placed in the trauma resuscitation unit, our emergency department. That allows us to get kind of hemodynamic stability. The orthopedic surgeons can then realign the pelvis with that C-clamp. From there, we can take off our pelvic binder, get a lot easier access to the pelvis at that point, and then from there we can go on to find whatever arterial lesion is bleeding and then embolize that, plus or minus laparotomy, depending on what the patient's injury pattern is. And from there, I think that we provide a much better integrated service that can all be seamlessly dealt with at the kind of index case, rather than having to move patients to intervention radiology and then back to the operating room to have their external fixator applied or whatever method you're using for bony stabilization. This is meant, with the advent of techniques like Reboa, that we've had to figure out ways of embolizing the pelvis that are maybe a little bit more unusual. In that if you've got a femoral catheter that's occluding your infrarenal aorta and occluding inflow, how do you go about embolizing the pelvis? You're kind of in this catch-22 when you've got arterial access, but you've got a balloon catheter through that every time you take down, you have a massive drop in blood pressure and active bleeding. So you're kind of in a little bit of a mixed position there. And that's allowed us to develop a kind of bunch of techniques where in this setting, if you put a Reboa catheter up, my preference is to then bring a sheath down from the radial artery, bring the balloon down a little bit, get that sheath passed. On the right-hand image, you can see this is my sheath here, and this then allows me to put another catheter. So from the radial artery, from above the diaphragm, I'll be able to get access to the pelvis, but I've still got balloon control of pelvic inflow. And this is very much a kind of trauma-specific endeavor that I don't think, I can't think of other problems that this would be used for, certainly in the setting of kind of elective pelvic embolization, which tends to be for things like, uterine fibroids and, prostatic enlargement and various things where hemorrhage is less of an issue. So this is an example of a kind of trauma-specific technique for an intervention that's been done for 30, 40 years. Here on the left is a picture of the balloon that's up. Here's our sheath. We've done an angiogram with the balloon up. We've now brought the balloon down, and we've now done another angiogram that allows us to kind of get the view with the heart in circuit. And here we can see that there is now extrav from the superior gluteal. So these are all kind of techniques that we have developed. Having radial access above the balloon in the setting of Reboa also allows us that once we take out the Reboa catheter, we're able to then do an angiogram of the puncture site and make sure that there's no issues with our femoral access. Because, alluding to what I said earlier in relation to complications, we certainly see a lot of access site complications with Reboa, and that isn't because we're terrible at arterial access, although maybe it is, who knows. But it's because these patients are hypovolemic, they are really sick, they tolerate any complication poorly, and therefore you've got to anticipate things. So having above diaphragmatic access and being able to angio in a kind of antegrade fashion allows us to assess all of those things. Does this make a difference? Well, that's a great question. This is a paper that we've just published jointly with our orthopedic colleagues in the Journal of Orthopedic Trauma, and certainly we found that over the course of 20 years, our mortality has fallen from 9.1 to 4.9% for hemodynamically unstable pelvic fractures. And while there isn't one single intervention, it's undoubtedly related to a bundle of care that we deliver. I would like to think that our trauma vascular service kind of nestles within that. In terms of other regions where we've developed specific techniques, the iliac arteries are another good example. Here is a paper that we just published, that our group just published in the Journal of Surgical Research, looking at iliac injuries, and we looked at two populations, those with a blunt injury and those with a penetrating injury, and we matched two groups from each. Those managed with endovascular intervention versus those with open intervention. And curiously, we found that those with an endovascular approach had a much lower limb loss rate, despite having a higher overall injury burden. And that I thought was kind of interesting, and we kind of took a bit of a deep dive into kind of our practice, and the things that we think about with iliac injury, either with penetrating injuries where we worry about concomitant hollow organ injury, venous injury, the resources you've got, whether your patient's stable. What's kind of started to dawn on us is that if you're able to preserve that retroperitoneal plane and not violate it by open exploration, you're often able to leave the venous injury that almost invariably exists. You're often able to leave that undisturbed. And let me tell you, whatever healing the body can do in the context of a venous injury, they can do it way better than anything we can do with proline. I think that combined with the fact that we are not violating another plane, where in the setting of contamination, we then don't end up with infected grafts and various things. We've kind of had a real active push to try and do more of our iliac intervention endovascularly, for all of those reasons. In patients where we do open exploration, we'll often reinforce any open stent grafts in the setting of penetrating trauma we'll often reinforce any open grafts with a stent graft inside that, which I know sounds nuts, but when you've managed a couple of patients that have had open interposition grafts that have then gone on to get infected and have then broken down, this starts to seem like a very sensible strategy. And this is certainly something that we've done a number of times. This is an example of a patient that had an aortic gunshot wound that we reinforced with a stent graft inside. There was also a lot of enteric content contamination that meant that this was very much a grossly infected field. Other imaging spin-off techniques that have kind of come as a byproduct of the service has been the availability of intraoperative computed tomography. What you see there on the left are what are called cone beam CT scans. This is where we use our C-arm to do a revolution that allows us to build up a three-dimensional image, just like multi-detector computed tomography, which is the kind of CT that I suspect you're most familiar with. What I show paired with those cone beam CT scans are the actual multi-detector CT scans, and certainly the algorithm that I've had in hemodynamically unstable patients that I take through to the hybrid room is I'll often start by doing a non-contrast cone beam CT of their head as a screening tool to be able to figure out if there's a brain injury and whether I need to be truncating surgery earlier, whether I need to consider involving neurosurgery earlier. This is just one of the things that is an added capability to having a hybrid room and a dedicated service that knows how to work all of this equipment. This is a recent paper that we published on that subject. So what we did before we had a hybrid room. We had a kind of, I would say, an unofficial but relatively complex way where if the patient was stable, we would undergo multi-detector CT, and then we would have the options of going to a multitude of locations, interventional radiology, to the ICU or to the operating room. And then with hemodynamically unstable patients, we would take directly to the operating room. They'll often require then trips to the CT scanner, maybe trips to the interventional radiology room, and then to ICU. And you know, it starts getting this kind of complicated journey. And with having a hybrid room, and I apologize, some of my animations haven't worked terribly well, we're now able to just take a patient that is, you know, really sick. We're able to take them directly to the hybrid operating room, where we can get both, you know, computed tomography images of the brain, as well as some of these urgent hemostatic or revascularization procedures. I would like to say that we then have the sense to just go straight up to the ICU, but usually we will end up a pit stop in CT just to be able to make sure that we haven't got any missed injuries and make sure we've kind of built up a picture of the whole patient's pathology. As I say, part of the kind of fun of a dedicated vascular trauma service has been this ability to develop novel approaches to old problems. That middle picture, well, this is our dual balloon technique for IVC injury. This is our infrarenal IVC gunshot wound, and what we have here in that middle picture is we've got the blue of the Reboa catheter, and then we've got the dark blue of our bridge balloon catheter. And this is a technique that we've used now, you know, half a dozen times, that I've found is a much more improved way of managing IVC bleeding than sponge sticks and pressing. And you know, this is something that I sometimes get into fights, you know, pleasant academic fights, not fisticuffs, with some of our older faculty who, you know, view a lot of these things as endovascular toys. But I am of the view that the balloon control is far superior to sponge stick control. You know, having done both and having failed miserably with the sponge sticks, I'll go to a balloon every time. Other areas where we're really trying to push the envelope is been in the setting of blunt cerebrovascular injury. We used to involve all of our neurointerventional colleagues in the management of these kind of traumatic carotid dissections. We've now moved to the world of flow reversal, where in order to minimize the risk of antegrade embolus with instrumenting these high up carotid lesions, we've now been doing a cut down onto the neck and establish an extracorporeal circuit from the carotid down to the femoral vein. And going from a high pressure system to a low pressure system then means that the flow in the carotid artery reverses and is no longer antegrade and is now retrograde. And that means that when we pass a wire into the carotid artery, if we dislodge anything, which is, you know, a significant risk with a lot of these fresh lesions, and if you look at this middle angiogram, this is a really tight stenosis with a pseudoaneurysm that you see with a kind of, you know, acceleration deceleration injury, and revascularizing these in the setting of antegrade flow is desperately unpleasant, you know, in terms of where that wire goes and what it may or may not disrupt on the way up. And having flow reversal gives you that confidence that whatever rubbish is going was going north is now being sucked into the filter, and that's kind of allowed us to kind of, as I say, push some of the envelope. In terms of getting into some really wild stuff, we've developed this technique called LESR, which is lower extremity staged reconstruction for patients with popliteal and distal SFA injuries. What we start by is number one, we acknowledge that we never do things as fast as we would like, and in the setting of ischemia, that becomes really problematic. Quite often, getting a bleeding patient to the operating room is not straightforward, but there's often a little bit more drama because there's blood on the floor. Whereas with an ischemic extremity, sometimes it can be a little bit harder to persuade, you know, the team to kind of move as quickly as you would like. So we've kind of developed this technique where, again, we use an extracorporeal circuit, just as you kind of would do in the setting of ECMO, where we'll have an antegrade femoral sheath, and then we will do a retrograde pedal stick
And then what we'll do is we'll just simply in the trauma resuscitation unit is we'll connect the two together with tubing. And while in the emergency department in our trauma resuscitation unit, that allows us to start the process of getting some perfusion into the extremity even before we started the revascularization. And then from there, this is an example of a very significantly disrupted popliteal, where we've then got a snare going antegrade, and then from our retrograde pedal access, we've then able to pass a wire that gets grasped. We get a wire across, then we have our orthopedic surgeons fix the knee in a straight position, and then we stent the popliteal artery. This is then followed at about 4 to 6 weeks by a definitive repair with an interposition graft, because we know from experience that these stents are not durable in the popliteal position, but they are, however, fast to deploy, and it allows us, in conjunction with getting these sheaths into patients for perfusion early on, this does allow us to get revascularization faster. But then we acknowledge that the durability of this is less good. So cutting this out and then putting in a interposition graft is what we do later. And this kind of lesser operation is kind of, we're finding our way with that. That's really kind of pushing the envelope. But really all of this then starts to provoke questions in relation to training. Who is it that we should train, and how are we meant to train them, and where should they come from? I'm aware that time is pressing, so I'm going to kind of zip through this. This is a kind of opinion piece that I wrote with a number of other senior surgeons and Joe DeBose, and it was kind of described as a as a kind of friendly article that basically suggested that vascular surgeons were less than enthusiastic about trauma care, and this provoked a deluge of criticism from some of our non-trauma vascular colleagues. But I think that this follow-up article from the group in Memphis, I think probably does it best, where you're trying to optimize patient care through collaboration, but I guess what I mean by that is you're trying to get the right practitioner to the right patient at the right time. And importantly, that practitioner has to be enthusiastic about what they're doing. Therefore, if you've got a vascular surgeon that wants to do trauma, then we should absolutely equip them with the trauma skills to do that. If we've got a trauma surgeon that wants to do the vascular trauma part, then I think that it's entirely reasonable and within their skill set to provide them with some additional training so they have some of these wiring catheter skills. Trauma surgeons, I think, very much have kind of patient ownership. They're involved in the kind of index resuscitation. They have very much, I would say, a holistic approach to patient care, and they obviously have a huge amount of open surgical expertise. Vascular surgeons, on the other hand, they tend to be consultants. They tend to be intraoperative opinions. They're often called late. And really, they're not part of the trauma team, although that very much is personality driven and kind of very much rests on the individual. But crucially, those practitioners have open and endovascular skills, and it's the endovascular skills that are really helpful in a pinch. Our endovascular radiologists, we'll just finish with the kind of point that interventional radiologists don't always do rounds, and they're very much kind of endo proceduralists, which if you can fit them into your paradigm of care where it doesn't slow down patient management, then great. But as I say, our experience has been somewhat different. I have, and I'm going to wind up quickly, a number of models for how we could take the 2-year trauma fellowship and switch out that second year for having a kind of dedicated year focusing on wire, catheter, and imaging skills. And I think that would really be able to equip trauma surgeons with the necessary wire and catheter skills. I don't think they necessarily need the kind of trauma experience because they'll have done a formal trauma fellowship. But really the only way that such a thing would work is if the credentialing and privileging was available and that they could be integrated into a sustainable service. We've kind of looked at this with the trainees that we've had come through shock and the amount of work that they do on our endovascular trauma service. By the time you compare them to vascular surgeons, interventional radiology, cardiothoracic and interventional cardiology, if you spent 6 months with our endovascular trauma service, you would pretty much meet the requirement for all of these specialties as published by the ACGME regulations. So there's certainly a way for people to establish that. Vascular surgery has other limitations. There are the two traditional and integrated paradigms now. I think that there would be a way of incorporating a vascular trauma track, and I think that that would need some additional time, or should I say some time spent within trauma and interventional radiology. And I think that that could be built into their programs, certainly in the 0+5 program, where you have more vascular time. There's certainly, I think, potential for that. But most importantly, it's got to be a sustainable service as to how this is delivered. And this has certainly been the learning point for me, is you can't be a single-handed practitioner. You've got to have support. And I think that this is why this particular piece is very much the preserve of high volume level 1 trauma centers that have the volume to justify such a dedicated service. And certainly what I think we would like to kind of build to is having, vascular trauma services. And I know that Shock isn't the only institution that has this kind of approach. LA County are considering that, as are the folks in Houston. And I think that it would be straightforward to have a kind of hub and spoke training model where interested practitioners from trauma surgery, vascular and interventional radiology contributed to these services. So I realize I'm a few minutes over time, but I very much appreciate everybody's attention. I've put a summary up there that folk can read as interested, but I'd be keen to take any questions. Thank you.
Dr. Morrison, thank you so much. That was excellent. It makes me miss my time at shock trauma. I open it up to anyone else that has any questions.
Johnny, Umesh Kidwani, you have done such a fantastic job starting literally from reimagining and re-engineering the physical space to obviously gathering a team that is so specialized. Isn't it important that every region have a center that is so comprehensively focused on trauma and erase the artificial borders between, let's say, a trauma surgeon, an orthopedic surgeon, vascular surgeon, etc.?
Many thanks for a very, I think, insightful question. There are kind of two sides to the scale in terms of getting balance with this sort of service delivery, and the two competing things as I see them are one, the volume to justify such a service, and two, having the system to be able to deliver it. And when I say system, not every hospital within a trauma system should have this sort of approach. Because you'll have a lot of people sitting around not doing much. And that's really the hard piece that you want to try and eliminate. You want to have that sweet spot where people are doing a sufficient amount of volume to stay sharp, but not so much volume that they are overwhelmed. It's fair to say that the majority of our cases are out of hours. And with having 2 or 3 people on a schedule, it means that you're on a 1 in 2 or a 1 in 3 call schedule. And that takes its toll. I'm on my first vacation in goodness, 4 years. So that's very much something that needs to be balanced. I'm hoping that we are starting to build the evidence base that says this is better for patients, because that's the fundamental driver of all of this. The marriage between vascular surgery and trauma surgery, I think, is one that at the bedside is a no-brainer. All of these skills very much overlap. critical bleeding, the effects of ischemia, these are germane to both people. But what I found in the administrative process of having that engagement and collaboration is just so much harder. And it's because different services have different pressures and different responsibilities, and the idea of being able to provide the majority of out-of-hours care, especially in cases that are often very messy. And some of the endovascular things that we will do, you know, we talk about perfection being the enemy of good. You know, for patients who are having you know, elective TVARs where you're worried about endo leaks and you know, various things, and you've got to be fastidious about how you do things. That isn't always the case in trauma, and you know, as a consequence, some individuals get on with that and some don't. But what all of that means is that these specialty boundaries, you know, are very much a thing, are a problem, and I've kind of stopped trying to think about it too much. And when somebody pitches up who is enthusiastic, then I'll endorse that wholeheartedly. You know, we now have intervention radiology trainees rotate with us. But then when you find people that aren't interested, then I try not to push it. You know, we don't have any vascular surgery trainees rotate with us at shock trauma from the medical center, which kind of blows my mind. You know, you can have a vascular surgeon train at Baltimore and never see a trauma patient. So, you know, you can take a horse to water, but you can't make it drink. So that's, you know, these are the kind of things that I think about. But yes, volume and how you structure your system, partly in how you can get your patients to those providers expeditiously, but also so that you concentrate expertise so that you get those volume outcome relationships. Hopefully that's not too much of a long-winded answer.
No, it's very succinct. Thank you.
Dr. Morrison, so I know, at least for the emergency department, there's been a lot of drama going back and forth about the Reboa catheters. Where do you see some of this fitting in with places that aren't necessarily shock trauma, that don't have a dedicated TRU, or in the community where the ED providers do a lot of this basic trauma and transfers? How do you see the training and transfers to these major centers like shock trauma?
So I think that's a great question, and I think it also touches upon the point that Dr. Gidwani was making in terms of how you structure service, how you know, do all the things to meet the demands of a specialty service. I think Reboa is a great example of how how it can either bring a group of specialties together, or it can lead to a lot of acrimony between specialties. You know, I come from the UK, and in the UK, Reboa is an intervention delivered by emergency department physicians. And that is never going to change. And I certainly don't want it to change. Philosophically, the way that the UK emergency care is delivered is that the emergency department physicians own and lead that space, and they're responsible for getting arterial access, and they are trained, you know, as are, you know, their US brethren. The problem is that in critical trauma patients, complications happen, and if you are the practitioner that causes that complication but can't manage it in its entirety, you have to call a friend. And if that friend is either is not familiar with this domain of practice and doesn't appreciate that, you know, as an example, you know, I've seen Dr. Scalea do a you know, groin cut down and cannulate the superficial femoral artery for a lower procedure. You know, and you think, you know, how on earth can you cannulate the SFA? Well, you know, CPR is ongoing. You know, there's blood everywhere. There's people bumping around the trauma bay trying to get venous access, and somebody else is trying to stick the groin on the other side. You know, this is just such a dynamic environment, and you know, that's why complications happen. So I think Reboa is a good example where people need to agree ahead of time, number one, that there's a need for this intervention, and then they're going to anticipate and support the complications that happen, acknowledging that every time that happens, it shouldn't be the case of, oh my goodness, an emergency department practitioner has injured a femoral artery. You know, that's a kind of nonsense approach that does nobody favors. And I think that these things, such as femoral arterial access, is going to become more and more critical to practice in the setting of endovascular resuscitation, where we start to use catheter-based therapies to augment physiology. And what I mean by that is, at one extreme, ECMO, where, you know, patients either, you know, cardiac or respiratory problems, you know, go on the pump, or patients who require interventions like selective aortic arch perfusion as a potential therapy for cardiac arrest. So I think all of these skills are going to become more and more important, and we need and are going to be pushed further forward. So I think that we certainly, as a vascular surgeon, has a duty to support our providers who are at the front line doing these sorts of interventions, and we need to acknowledge and accept and be content with the fact that complications will happen. I think that some of these endovascular resuscitation things, and I include Reboa within that, may serve as bridging therapies in order to get patients to a higher level of care. But until we have worked out issues of ischemia that's incurred by the balloon, I certainly wouldn't at this point consider Reboa ready to be used as a transfer tool in hemodynamically unstable patients.
And that's a great answer. Thank you so much. And as you said, I am totally in agreement. But that was an amazing lecture. Thank you so much. I greatly appreciate your time and hope you enjoy the rest of your vacation.
Oh, no, pleasure. Thank you. All right. Thanks for having me. Yeah, hope everybody has a great Thursday. Take care.